Welcome to the deep dive. Today we're tackling a really vital chapter, ophthalmic drugs specifically tailored for Canadian healthcare practice.
Absolutely. It's all about extracting that core knowledge you need without getting lost in, overly dense text.
Exactly. Our mission is a focused summary, understanding the key drugs, how they work, why we use them, and importantly, the side effects and nursing points.
And the eye is, well, it's unique. It's got barriers. So drug delivery is tricky.
Right, so we'll cover the basics, the anatomy needed, then get into glaucoma treatments and other common eye meds, and critically, how to manage these safely in practice.
Because these aren't just local treatments, are they? Treating eye disorders, especially chronic ones like glaucoma, relies on targeted delivery, sure. But there's always that potential for systemic absorption.
Ah, okay. So local drops can have body-wide effects. That's key.
It really is. Administration technique becomes just as critical as picking the right drug. So yeah, let's unpack that balance.
Okay, let's do it. Before the drugs, let's understand the target structure, the eye. Maybe not the vision parts like rods and cones right now, but the plumbing, almost.
Good analogy. So
Yeah.
you've got the cornea, the front window, the lens focusing light, lacrimal glands making tears.
Which have lysozyme, right? That natural antiseptic.
Correct. But for glaucoma, the crucial part is the fluid dynamics inside. We're talking about aqueous humor circulating in the front chambers.
And that fluid creates the intraocular pressure, or IOP.
Exactly. There's a constant production of this aqueous humor by the ciliary body. Think of it like a tap that's always on,
Okay, taps on.
and it needs to drain out. That happens primarily through a structure called the canal of Schlemm. In a healthy eye, production perfectly matches drainage. Pressure stays stable.
Got it. So glaucoma is when that system breaks down.
Precisely. If the drainage gets obstructed or if production ramps up too much,
Right.
basically if outflow can't keep up with inflow.
Then the pressure inside the eye, the IOP, starts to climb.
Right. And that increased pressure pushes backwards. It compresses the vitreous humor, that gel-like substance filling the main part of the eye.
And that pressure damages the optic nerve and the retina.
Yeah, that's the devastating part. Sustained high IOP leads directly to optic nerve damage and eventually irreversible vision loss. The sources show like a flowchart. High IOP, nerve damage, blindness.
It's important to know there are different types, though.
Oh, definitely. Two main types, and the difference matters for treatment. First, there's closed-angle glaucoma.
That sounds acute.
It is. It can be an emergency. It happens when the physical angle between the iris, the colored part, and the cornea narrows, literally blocking the drainage pathway. Vision loss can be rapid.
Okay, a physical blockage. What's the other type?
The more common one is open-angle glaucoma. This is usually chronic, develops slowly. The angle itself is physically open.
Got it.
But the canal of Schlemm, the drain pipe, is obstructed, usually by some kind of tissue abnormality. So the pressure builds up gradually, often unnoticed at first.
So regardless of the type, the main goal is always to lower that IOP.
That's the mission. And we do that basically in two ways. Either help the fluid drain out better, or turn down the tap, reduce how much fluid is being made.
Right. Which brings us to the drugs, the IOP managers. Let's start with those that improve outflow. The cholinergics or miotics, like pilocarpine.
Yes. These work by stimulating the parasympathetic nervous system receptors in the eye. This causes two main things: miosis, which is pupil constriction.
Making the pupil smaller.
Right. And it also causes the ciliary muscle to contract. That contraction physically pulls the iris tissue away from the drainage channels.
Ah, so it mechanically opens up the space for the fluid to drain.
Exactly. It widens that trabecular meshwork area leading to the canal of Schlemm, enhancing outflow. It's pretty effective, can lower IOP by 20, maybe 30%.
Okay. Any quirks with these?
Well, yeah, an interesting one. The sources mention that people with darker eyes, brown or hazel, might get less of a myotic effect.
Why is that?
The theory is the pigment in the iris actually absorbs some of the drug, reducing the amount that reaches the target receptors.
Huh. That's a fascinating detail, important for setting expectations. What about side effects?
Mostly local. Blurred vision is common, especially initially. And because the pupil is constricted, patients often have trouble seeing in dim light or at night. Some eye or brow pain, too.
Okay. Now, another class affecting outflow, but maybe counterintuitively, sympathomimetics, like aproclonidine. These cause mydriatics pupil dilation, don't they?
They do, which seems odd for glaucoma, especially closed angle where dilation is bad.
Yeah.
But the key here is which receptors they hit.
Ah, good.
It's the alpha receptor stimulation that's beneficial. This actually increases aqueous humor outflow through a different pathway, and it also slightly reduces its production, so a dual effect.
So it helps outflow and turns down the tap a bit.
Exactly. Abraclonidine, for example, is often used specifically around eye surgeries to prevent those temporary but potentially dangerous spikes in IOP.
Side effects, still mostly local.
Usually, yeah. Burning, stinging, eye pain.
Yeah.
But because they mimic the sympathetic system, there is a small risk of systemic absorption causing things like increased heart rate or blood pressure. Rare, but possible.
Which again highlights why proper administration is so important. We'll get to that.
Definitely.
Okay, let's switch gears to the drugs that primarily reduce production. The big category here is beta-adrenergic blockers. Timolol, betaxolol.
Right. These are workhorses for glaucoma. Their mechanism is straightforward. They decrease the formation of aqueous humor by the ciliary body. They effectively turn down that faucet.
Timolol is non-selective, right? Beta-1 and beta-2.
Correct. While betaxolol is beta-1 selective or cardioselective.
And that selectivity matters because
Because of potential systemic side effects. If these drops get absorbed systemically, non-selective beta blockers like timolol can potentially cause bradycardia, slow heart rate via beta-1 blockage.
and bronchospasm, breathing difficulties via beta-2 blockage. That's a huge concern for patients with asthma or COPD.
Exactly. So betaxolol, being beta-1 selective, theoretically carries less risk of causing respiratory problems. Though it's worth noting, significant systemic effects from eye drops are generally uncommon if used correctly.
Still, the risk is there. Anything else notable about beta blockers? The text mentions glucose.
Yes, good point. While oral beta blockers can sometimes affect glucose metabolism, the sources specifically state that these ophthalmic ones haven't been shown to do that. So one less thing to worry about there.
Okay. Another production reducer, carbonic anhydrase inhibitors, or CAIs. Dorzolamide is an example.
Right. These inhibit an enzyme, carbonic anhydrase, which plays a role in secreting aqueous humor. Block the enzyme, less fluid gets made. Simple as that.
What's the big caution with these?
Their chemical structure. CAIs are sulfonamides. They're chemically related to sulfate antibiotics.
Oh, so potential for cross-allergy.
Exactly. Patients with a known sulfa allergy need to be aware of this potential, even though it's a topical eye drop. It's about informed caution.
Definitely something to flag during patient teaching. All right, now, for a really interesting class, often first-line treatment these days, prostaglandin agonists. Latanoprost is the common one.
Yeah, these are very effective, and a big plus is they're usually just once daily dosing, which is great for adherence.
How do they work? Still reducing production?
Nope. These guys primarily increase outflow of aqueous fluid, but they use a different route than the cholinergics. They mainly enhance outflow through what's called the uveoscleral pathway, sort of a secondary drainage system.
Okay, increased outflow, convenient dosing. Sounds good. What's the catch?
The catch is quite noticeable and permanent. These drugs, especially latanoprost, can cause darkening of the iris.
Permanent darkening.
Permanent darkening. It's due to increased melanin pigment. It's most noticeable in people with lighter colored eyes, hazel, green, blue-brown mixes. And even if you stop the drug, the color change stays.
Wow, that's
Yeah.
significant.
It is. And they also famously cause eyelashes to grow longer, thicker, and darker, sometimes seen as a cosmetic plus, but the iris color change is the big one patients need to consent to.
Definitely a major counseling point. Okay, that covers the main glaucoma drugs. Let's quickly touch on other ophthalmic categories, starting with antimicrobials.
Sure, used for infections, obviously. Things like conjunctivitis, pink eye keratitis, which is corneal inflammation, or a simple stye. Also used sometimes before surgery to prevent infection.
Examples.
Lots of them. Tubramycin, an aminoglycoside, good for tougher bacteria. Erythromycin, a macrolide, classic for preventing eye infections in newborns. Ciprofloxacin, a quinolone.
Does Cipro have any specific eye side effects?
Yes, it can sometimes cause these little white crystalline deposits to form on corneal ulcers or lesions. Looks a bit weird, but it usually goes away on its own. And for viruses, like herpes simplex affecting the cornea, we use antivirals like trifluridine.
Got it. Then we have anti-inflammatory drugs, NSAIDs, and corticosteroids.
Right. Used to reduce inflammation, swelling, redness, pain. Often used after eye surgery, like cataract extraction, to calm things down and prevent scarring.
Corticosteroids like dexamethasone are powerful, though. Any major cautions?
Big caution, immunosuppression. Because they suppress the immune response, you absolutely should not use steroid eye drops if there's just a minor scratch or an untreated wound.
Why not?
Because you're basically shutting down the eye's natural defenses against bacteria, viruses, or fungi. You could turn a small problem into a severe infection. Steroids are only for when inflammation is the primary issue, and usually after infection is ruled out or treated.
And NSAIDs like ketorolac.
They can be very effective for pain and inflammation, but there's some evidence they might delay wound healing in the eye, or, rarely, cause breakdown of the corneal surface. Needs careful monitoring.
Okay. What about numbing drops? Topical anesthetics like tetracaine.
Yes. These work super fast, numb the eye surface within seconds by blocking nerve signals. Great for short procedures in the clinic, like removing a speck of dust or measuring eye pressure. Lasts about 15–20 minutes.
But patients shouldn't use these themselves, right?
Absolutely not. This is a critical nursing point. These are never for self-administration or repeated use at home.
Why the strong warning?
Because a numb eye loses its protective blink reflex. The patient can't feel if they injure it. Repeated use can lead to delayed healing, breakdown of the cornea, potentially even perforation and permanent vision loss, strictly for supervised, short-term clinical use.
Very clear. Don't send patients home with anesthetic drops. Finally, diagnostic and anti-allergic drugs.
Right. For diagnostics, we use drugs to dilate the pupil mydriatics and paralyze the eyes, focusing multicycloplegics, things like atropine or cyclopentolate. This lets the examiner get a clear view of the retina and optic nerve inside the eye.
And that
Fluorescein sodium. Brilliant stuff. It's a yellow dye that stains areas where corneal cells are damaged or missing. Under a special blue light, these areas glow bright green or yellow-orange. It highlights abrasions, ulcers, or even where a foreign object might be sitting. It'll often show a green halo around it.
Cool. And anti-allergics.
For itchy, watery red eyes from allergies, allergic conjunctivitis, we have antihistamines like olopatadine, mast cell stabilizers like cromolyn that prevent histamine release, or simple decongestants like tetrahydrozoline that constrict blood vessels to reduce redness.
Okay, that's a comprehensive tour of the drugs. Now let's bring it back to the bedside, or the clinic chair. Administration, you said earlier it's critical.
Hear 'em out. Especially for preventing those systemic side effects we talked about. Technique is everything.
So walk us through the key steps. What's rule number 1?
Rule number 1, prevent contamination. Check the expiry date, make sure the solution looks right, clear, or properly mixed if it's a suspension. And the absolute golden rule, never touch the tip of the dropper bottle or ointment tube to the eye, the eyelid, eyelashes, or any other surface.
Keep it sterile. Makes sense.
Yeah.
Rule 2, where do the drops actually go?
Into the conjunctival sac. You gently pull down the lower eyelid to create a little pocket. The drop goes in there. Not directly onto the cornea that can be uncomfortable and cause blinking, which squeezes the drop out.
Okay, into the pocket. Now the most critical step for safety, preventing systemic absorption.
Yes. Immediately after putting the drop in, the patient or the nurse assisting needs to apply gentle pressure to the inner campus. That's the corner of the eye right next to the nose, over the lacrimal duct, the pier duct.
And hold that pressure for how long?
For at least 1 full minute, 60 seconds.
And why does that specific action work?
Because it blocks the entrance to the lacrimal drainage system. It prevents the medication from quickly draining out of the eye, down the tear duct, into the nasal cavity, where it can be easily absorbed into the bloodstream.
So that 1 minute of pressure is literally stopping the drug, like a beta blocker, from reaching the heart or lungs systemically.
That's exactly it. It keeps the drug localized in the eye where we want it and minimizes the risk of systemic side effects like bradycardia or bronchospasm. It's probably the single most important technique point.
Absolutely vital. What other key teaching points do patients need to hear?
Several important ones. If they've had dilating drops, mydriatics, they must wear sunglasses. Their eyes will be extremely sensitive to light.
Makes sense.
If they've had anesthetic drops, remind them forcefully, do not rub or touch the eye. They can't feel injury.
Right. Contacts.
Contact lenses generally need to be removed before putting in any eye drops, unless specifically told otherwise. And usually they should wait a certain period, often 15 minutes or more, before putting them back in, or sometimes leave them out entirely during treatment. Check the specific drug info.
Good point. And when should they call for help?
They need clear instructions to report any serious signs immediately. Worsening eye pain, increased redness or discharge, swelling, fever, or any sudden change or decrease in their vision. Don't wait.
Okay. And evaluating if the treatment is working.
It depends on the goal, right? For glaucoma meds, we're looking for a measured decrease in IOP. For antimicrobials, we want resolution of infection, less redness, discharge symptoms gone. For anti-inflammatories, reduced pain, swelling, redness.
Perfect. So let's try to wrap this up. A final recap.
Okay. Ophthalmic pharmacology is this careful balance, isn't it? We need precise local action in the eye, but we constantly have to be vigilant about that potential for systemic absorption and side effects.
Right. The anatomy is the map, glaucoma is the traffic jam.
Ah, I like that.
And the drugs clear the jam by either opening the outflow channels like the miotics and prostaglandins, or by slowing down the fluid production like the beta blockers and CAIs.
Well put. And that nursing piece, applying pressure to the inner canthus after installation, that's your number one tool for keeping the patient safe from systemic effects. Don't forget that minute of pressure.
Absolutely crucial takeaway. Okay, before we finish, our final provocative thought for you, the listener. Considering that side effect of permanent eye color change with drugs like latanoprost, what kind of ethical or maybe psychological discussion should happen? Especially when a patient has to weigh preserving their sight against an irreversible change to their appearance. Something to think about.
Definitely food for thought.
Thank you for diving deep into ophthalmic drugs with us today.